All right, so the agenda for today, we're going to do some introductions, who's here with us today. Then we'll go into just an overview on arrhythmias more generally. Then we will deep dive into each of the arrhythmias. Let's talk a little bit about how Kardia can help you with arrhythmia management. We'll spend some time at the end for Q&A. We're planning on spending about 15 minutes on Q&A, so save some of your questions for then, and then we'll just close at the end of the session. And I see we have Ashley who has joined us as well. So Ashley, I'll hand it off to you to do some quick introductions.
Sounds great. So happy to join everyone. I see 800 and some people already on. Welcome, welcome. I'm Coach Ashley Triban. My background is in employee health and wellness, but also health coaching. So I'm a board certified health coach, also a board certified lifestyle medicine professional. And here at AliveCore, I get to help with engagement and creating engaging programs and features in our subscriptions for you, our Kardia community. So I'm really excited to be part of this conversation today. Dr. K is our star. So Dr. Kozlowski, go ahead and introduce yourself.
I am really pleased to see such a large turnout and to see the interest in learning about arrhythmias. My name is Dr. Chris Kozlowski. I'm a longtime interventional cardiologist, and I'm one of the medical directors here at Kardia and AliveCore.
All right. And you heard a little bit from Katie. We couldn't do this without her. She is our director of product management. She keeps all the wheels going and behind the scenes. Katie, go ahead and introduce yourself and our behind the scenes team.
Yeah. Hi, everyone. I'm Katie Carr. I work on our product team at AliveCore. I am responsible for our Kardia application and also work on some of the hardware and algorithms that you get to experience within the Kardia app. I will be helping out today with some of the Q&A. Just to note, we did receive over 600 questions prior to the session, and I did read through every single one of them. We were able to sprinkle a lot of them throughout the presentation, and we did save some of the more popular ones towards the end. So as mentioned, we'll try to get through all the content in about 40 minutes so that we can leave about 20 minutes for Q&A. We also have two team members on the call to help us with Q&A throughout the session. So Rosie and Daniel will be managing the Q&A. So at the bottom of your screen, you should see a Q&A button. Feel free to tap that and ask questions there as we go throughout the presentation. Rosie and Daniel will do their best to answer those, and we can also answer a few of them live. So feel free to just drop them in there as we're going through. Okay, I think that's it from a logistics perspective.
All right. Well, Katie, as we talk about arrhythmias and this big kind of overview, we want to launch a poll to see why everyone showed up today. What are they interested in learning about? You can select as many as you'd like. So that poll is live now. Thank you, Katie.
Seeing a lot of interest in atrial fibrillation. Hopefully some of you saw that we actually did a session a couple months ago about AFib. It's posted on YouTube. I think Rosie can also drop the link to that in the chat, but would highly recommend watching that if you have not already seen that session.
We got 600 responses already. This is a very engaged crew.
All right, I'm going to go ahead and end it and share the results with all of you. Dr. K, we're covering a lot of these, lots of AFib, AFlutter.
Okay.
There you
go. Awesome. All right, Dr. K, you ready? Let's dive in. What is an arrhythmia?
An arrhythmia is any abnormal electrical rhythm in the heart. From that list that we just saw, there are many arrhythmias. We have a lot of material to cover today. Not surprising to see that there's a large interest in atrial fibrillation, which is the most common and one of the most important rhythms that we see. I would like to say that we're going to go fast. I want to leave as much time as possible for questions, but I also want to commit that we are willing to come back in the future and revisit in a little bit more detail some of these rhythms that we might not be able to cover as thoroughly as we might like today. Almost 3 million people a year in the United States are diagnosed with a new rhythm problem. That's in addition to those who already have known rhythm problems. At least 1 in 3 Americans are at risk of developing serious rhythm problems of the heart, many of which are life-threatening, but many of which are also quite benign, and we'll touch on that today. And of course, I think most people know that many people unfortunately still die before they're able to be transported to the hospital for further care. Most of this sudden cardiac death is due to ventricular arrhythmias, ventricular tachycardia, and ventricular fibrillation, which are most often associated with heart attacks. Next slide, please. So there are a lot of arrhythmias. We listed about a quarter of them on when we asked for the poll there. And so we have means of organizing them and categorizing them so that we can keep track of things. The simplest way is to divide the rhythm problems or the abnormal rhythms of the heart based on the heart rate itself. Tachycardias are arrhythmias that demonstrate a fast heart rate, where bradycardia or bradyarrhythmias are problems that are manifested by low heart rates, and there are subcategories of these classifications. Equally importantly, we can divide the arrhythmias based on where in the heart's electrical system they start. We'll see in a moment the normal electrical system of the heart, but keep in mind that pretty much any area in the heart, both in the electrical system as well as in the regular muscle cells of the heart, do have the capacity to initiate heartbeats and to participate in the arrhythmias that we'll be seeing. Next slide, please. And so this is a picture of the 4 chambers of the heart. We see the right atrium and the left atrium. Those are the top chambers. And we see the right ventricle and the left ventricle on the bottom, which are, of course, the bottom and main pumping chambers of the heart. The electrical tissue, it's not unreasonable to think of this tissue as a wire, if you will, in the heart. Importantly, at the top, we see the sinus node. This is an area of cells that automatically provide a spark, if you will, which initiates the normal heartbeat throughout our life. The electrical initiation then passes down through the atrium to the area called the AV node. This is a very important area, and it's where the top chambers of the heart speak electrically to the bottom chambers of the heart. Once that signal passes through the AV node, that electrical message is distributed along the left bundle branch block toward the left ventricular and to the right ventricle, which supplies the septum between the ventricles as well as to the right ventricle.
A quick note there, Dr. K. We talked about before, we're talking right now about when the heart kind of misfires with these arrhythmias, but your heart's going to beat about 115,000 times a day. So we have to give it some credit, right?
We have to give it some credit. It's a sophisticated design that works for the most part extremely well throughout our lives until we start to develop some arrhythmias that let's get into these here. So that next slide. So that electrical activity in the human organ of the heart can be recorded by placing electrodes on the skin. That's what an EKG does. We've been recording EKGs for over 100 years already and continue to learn more to this day. The atria contract first. They inscribe or produce a P wave on the EKG. Those are the atria. Then that electrical system goes through to the ventricles. The electrical message causes the heart muscle to depolarize and squeeze, giving us the QRS. That is the depolarization or the squeezing function of the ventricles. And then the heart resets itself throughout our lives and after every heartbeat. This repolarization or resetting of that electrical system is manifested on the EKG by the T wave that we see here. And then the heart resets itself and we go through that entire cycle again, hundreds of millions of times throughout our life. So that's the normal looking EKG. Next slide, please. So we said that the rhythms can be divided into slow and fast. Let's take a moment and look at the slow problems that we have. On the upper left here is that P, QRS, and T wave repeated about 10 times there in the normal manner. On the lower left, we see a heartbeat where there are P waves connected to the ventricular QRS waves and normal T wave repolarization, but it's overall slow. We can measure time from the left to the right or on the x-axis, if you will, down to the level of milliseconds. And this heart rate here looks like it's about 45. And it is slower than average. And when the heart rate gets too slow, it starts to produce symptoms. And this is typically one of the several situations where patients might need to get a pacemaker to improve the rate. On the upper right, we have a slightly different problem. We see two normal beats. Remember, we just saw that the sinus node is responsible for initiating the normal heartbeats. And in this case, the sinus node is showing some wear and tear. It does tend to wear out as we get older. There are risk factors for how that occurs. Drugs may be involved, but what has happened here is that there's no heartbeat for, it's roughly about 3 seconds. That's long enough to cause symptoms. And if we can't identify something that's reversible to fix that pause, that's another indication for which patients might receive a pacemaker and do quite well with that. The other slow heart rate that we see is a little different. This one is called AV block. So remember that the normal sinus beats communicate to the lower chambers of the heart through that area that we call the AV node. The electrical fibers kind of concentrate there before they are dispersed into the lower chambers. It is not uncommon to see block in the electrical system. The blocks get pretty complicated. Some of the P waves get through, some may not get through. They may be delayed in getting through. We're not going to get into that level of differentiation. But in this case, we actually can see the little P waves. If you see on the first beat, there's a P wave, a QRS, and a T wave, and then we see a couple of P waves that aren't really connected to anything. We do see another QRS that has arisen, in this case, somewhere else in the electrical system. But here, these P waves are not really talking to the ventricles. They are blocked, and this would be another indication to get a pacemaker. I want to point out, we're using the word block a fair bit here. We're talking about electrical blocks today. These are not what people often think about with blocks in the heart when we're referring to blocks in the coronary arteries or the coronary circulation, which provides the heart with its own oxygen and thereby the energy with which the pumping or muscular function of the heart occurs. Blocks in the coronary system can result in some of these electrical blocks, but keep in mind that for today, we're talking about blocks in the electrical system. Next slide, please.
Dr. K, before we jump to the next slide, just two quick questions. I saw a question come in, and you mentioned medications can cause bradycardia. The question was, can bradycardia be caused by beta blocker medications?
Beta blockers can commonly cause, particularly on the lower left, sinus bradycardia, which we don't worry about too much unless it causes symptoms, but they can also cause AV block or suppress the sinus node, the two on the right. Beta blockers, calcium channel blockers, rhythm medications for atrial fibrillation, of which there are many, can also result in these blocks. So we have to be on the lookout for them.
Great. Thanks for your question.
Okay. So now we're going to move quickly to the fast rhythm problems, the tachyarrhythmias. Again, I know we're going fast. Normal rhythm on the upper left, excuse me. Ventricular tachycardia on the upper right. We see 3 normal beats. We see a skip or a PVC, which we'll talk about in a moment right after that, and that triggers a potentially serious problem called ventricular tachycardia. Again, there are several types of ventricular tachycardia, at least 4 or 5 different. Some are actually surprisingly benign. Many of the ventricular tachycardias can be life-threatening. There are several mechanisms that produce VTAC. Coronary blockage very commonly, also conditions like long QT syndrome and a couple of more uncommon ones. These need attention. On the lower left, we see another rhythm. This is supraventricular, which is a long word, which simply means above the ventricle, or of course, the atria. We know that these start in the atria because unlike the VTAC on the upper right, these complexes are narrow and very fast. This heartbeat right here is going at almost 300 beats a minute, and there are clues on it that tells us where it started. In this case, we've got a little short circuit in the AV node, which results in this. These are great rhythms to record on a Kardia device. The more if you are prone to this, the more you can get, the better we can plan how to treatment. And this is a curable rhythm problem with an ablation. There are similar rhythms called I don't want to get into too much jargon, but if you've heard of patients with Wolff-Parkinson-White, they'll have rhythm problems that are very similar to this one. The least common supraventricular or atrial fast rhythm problem is called atrial tachycardia. And on the lower right, we see 3 normal beats, and then there's a series of about 6 or 7 beats that are much faster. In this case, an area of the heart probably next to or in the vicinity of the sinoatrial node, the regular pacemaking part of the heart. It can come from either the right or the left atrium, have decided that they want to take over for a little while and pop off a few fast heartbeats until the heart resets itself with that pause and resumes a normal rhythm. This is the least common of all of them, but we see so many EKGs at Kardia. I think we see these just about every day, as well as the other ones just about every day. Next slide, please.
Actually, sorry, Dr. K, pause quick on that slide. A couple of things to call out. Number one, we got a question in the chat. What of the determinations does Kardia identify? And those are actually going to be indicated with that little star next to the determination name. So we do call normal sinus rhythm. On the previous slide, we call sinus bradycardia. So those both have the stars. So those are things that you can get with a Kardia device.
The Kardia device computer algorithm, we like to call it artificial intelligence. Frankly, it's almost artificial intelligence. It does require some human interaction to improve the algorithm, not quite able to distinguish among all of these types of fast rhythms that we just saw. So that's an opportunity to get a physician overread and we can make a number of more determinations. We're working on it. We're getting better at it, but the algorithm presently has a hard time distinguishing among these with a sufficient degree of accuracy. Okay, if that makes sense. Yeah.
Yeah, that was great. Two other things. Number one, most of these EKGs that are being shown are on lead 1. There will be a couple examples later on that will show additional leads, and we will talk about that when we get to those particular slides. And then, Dr. K, one last question. You've kind of discussed this a little bit. We don't detect SVT with our algorithms right now on Kardia devices. So if someone does have SVT, how would you recommend they use the Kardia device to monitor that?
There's not a single answer for any of these kind of broad questions. In patient, it's better to record as many of the symptomatic episodes as you can. If you can catch the beginning when the heart rate goes fast, most people feel these to varying degrees, and then catch when it breaks. This provides a clue to the mechanism. Recording a normal heartbeat all the time doesn't provide a great deal of additional information, but I would emphasize using this device, keep it at hand, and record when you have symptoms. That's the best way to get a lot of good data. We can't see all of them, but they all live in your phone, and you can either request a visit with the cardiologists that do this. I'm the medical, we've got about 20 or 25 cardiologists across the country. And I enjoy going over these rhythms with individuals, and we can spend some time and really make things pretty clear as to what's going on. You can ask for a physician overread, or you can simply keep them in your phone and show them to your regular physician at your regular visit.
All right. Well, Dr. K, we are about 20 minutes in already. Can you believe it? And we are about to tackle our biggest one. So I just want to remind everyone that we have a whole presentation dedicated to this topic. But go ahead, Dr. K.
We're gonna have to go quickly. Atrial fibrillation is the most common supraventricular rhythm encountered in the cardiology office. That's because it's the most common rhythm, and it's also the rhythm that has a pretty high degree of morbidity and mortality associated with it. So this is an important topic. The risk factors for developing atrial fibrillation are similar to those for developing a block in the coronary arteries. Additionally, sleep apnea, if you have CPAP, is a risk factor independently for AFib, thyroid gland out of whack, excessive alcohol and caffeine, and importantly, obesity. Obesity seems to be kind of a general risk factor for a lot of things with the heart, but it's become clearer just recently that managing obesity, that is, if you have AFib and obesity, if you lose weight, it is remarkably effective at improving how much AFib you have. The symptoms are palpitations and lightheadedness. We're also concerned about AFib because when the heart beats irregularly, blood pools in the heart, in which case it can form a clot, and those clots can break off. 80% of the time, those clots will go to the head, and that's a cause of stroke, and we certainly don't want that to happen. That's the indication for blood thinners for patients with AFib. Occasionally, a Watchman device is used for patients that need blood thinners, but for whatever reason cannot tolerate them. We always have to balance the risk of bleeding from blood thinners against the perceived benefit for using blood thinners to prevent stroke. And we have pretty reliable and simple methods to do that. Let's move on, please. This is atrial fibrillation on the top. A little slower than we might see, but it's characterized by its irregularity, the lack of P waves, and the fact that there's no I guess it's called irregularly irregular. There's no pattern to the irregularity. We see it every day when we read these on the web portal. On the bottom is a related rhythm called atrial flutter. It's not quite as irregular, and it's distinguished on the bottom by what's called the sawtooth pattern. I think you can agree that that might look like the edge of a saw that you might use to cut wood. There is overlap between these two. I wouldn't go as far as to say that they cause one another. It's more that they unmask or commonly reveal one another. And we can get into that if there's a little bit more time. The stroke risk is the same, and at the outset, they're treated the same. Thank you. Next slide.
Sorry, Dr. Tay, on that last slide, the one question we had is, can you talk about the connection between the two, and is it possible for AFlutter to progress to atrial fibrillation?
As they say, they don't typically progress, but they unmask. They don't cause one another, but they can make it apparent that both they overlap. So they occur at different areas in the heart. Atrial fibrillation is understood nowadays to occur near or to be initiated in the pulmonary veins. There are 4 of them that drain blood into the left atrium. We know that's where most AFib starts electrically. AFlutter is really in a different area of the heart, typically down in an area called the isthmus of the heart, but there are variations and overlaps. So I don't know if they progress into one another. They both need to be treated. The stroke risk is the same. They both need to be anticoagulated, and the treatment's a little variable, but really quite good for both.
Great, thank you.
Let's talk about skips briefly. Skips, most people feel as palpitations or thumping in the chest. Many people don't feel them at all, and some people have severe symptoms. Caffeine, alcohol, hypertension, physical stress a little bit more than psychological stress, although psychological stress can cause them to happen as well. These are skips. If they occur in the top chamber of the atrium, they're called PACs. If they occur in the bottom chamber, they're called PVCs. Let's just look at a couple quickly here. So, next slide. On the top, we see a couple of PVCs. We see two normal beats. We see a characteristic large voltage, wider complex. The heart then kind of resets itself and pauses. It still fills with blood and then resumes the normal rhythm. And then a couple beats later, we see one that it's a PVC that actually points the other way, that tells us that there are 2 areas, typically down in the right ventricle, but really anywhere in the ventricles decide that they want to initiate the heartbeat, and we record these on the EKG very commonly. On the bottom, we have that's an okay example of a premature atrial contraction. Again, a skip that originates in the top chamber at 3 normal beats. You might be able to see that P wave that the arrow was pointing at on the bottom has a little bit different shape. The next beat's a little bit earlier in the cardiac cycle than we would have anticipated for a normal beat. That different looking P wave, and the fact, remember, the P stands for premature. So it's a little bit early. Then you can see that the heart resets itself. That's a common example of a PAC. I've had plenty of those myself. They're not particularly comfortable, but importantly, neither the PVCs nor the PACs confer any significant risk to poor cardiac outcomes unless they're very, very high frequency, by which I mean about 10,000 a day. So that's not too common. Occasional skips are not dangerous.
Lots
Okay.
of questions on this particular topic.
I bet. Let's keep moving here.
Can I jump in 2 things? So number 1, again, these are both items that we can identify with our Kardia algorithms. If you are a Kardia Care or a Kardia Care Plus subscriber, you will have access to these. we have questions about what is sinus rhythm with supraventricular ectopy. That is, I think, another name basically for PACs. So that is what that means.
It's typically for PACs. It gets a little fussy. There could be things called premature junctional contractions and a few others. So supraventricular ectopy is a mouthful that basically means PACs. That's correct.
Great. Two other quick questions. Number one, can menopause cause PVCs?
Any physiologic stress, by which I mean anything from a stomach ache to a severe influenza to you sprained your ankle and it hurts, can theoretically cause skips. We see palpitations in menopause. There are pretty big hormonal shifts. That's definitely a physiologic stress. And the short answer is yes. So PACs, right.
You're getting a lot of thumbs up on that.
I
So I
see a
think
lot of
people
hearts and
appreciated
thumbs
that
up. That's
question.
great.
The other question was, is there anything that people can do to prevent PACs or PVCs?
We can do the conservative stuff, staying hydrated, exercising, avoiding caffeine and alcohol, avoiding those physiological stress are all reasonably effective. Physicians and their patients love to spend time, hours, trying to figure out what's triggering PVCs and PACs. And to be honest, it's not a particularly rewarding exercise. About maybe a third of the time we can identify it. And the answer is the heart just wants to do what it wants to do. Most people will have these. They are benign. They can be treated with medication. I really like to reserve medication for those that have very prominent symptoms because they're not dangerous. We're not living longer or preventing any heart attacks or anything by treating these skips, but there is treatment available. Wide QRS, okay. So the QRS, remember we talked about measuring the time from the top chamber of the heart to the bottom chamber of the heart. That's the AV time. The QRS measures the time side to side, not top to down, but side to side between the left ventricle and the right ventricle. Normally, the left ventricle contracts about, I don't know, about 20 milliseconds, 20 thousandths of a second before the right ventricle. And there can be electrical blocks, just like there are electrical blocks top to bottom in the heart. There can be electrical blocks side to side in the ventricles, and they can be blocked from the left to the right to the left, both ways at once. And we are able to measure the duration of that electrical block. On the bottom, we see a wide QRS. So without getting too many numbers involved, the QRS is normal up to about 120 milliseconds. That's from the beginning of the ventricular contraction to the end of the S wave. 120 to 150 is kind of an intermediate zone. And then above 150, we start to get the right bundle or the left bundle when they're that wide. I do want to mention that these non-specific ones, like we see here, not particularly dangerous, notable, but really not conferring any additional risk unless, on the next slide here, they do get wider. On the left, we see a common finding called a left bundle branch block. This pattern, especially if it's a new finding for you, this pattern can be seen with new underlying plumbing or coronary block. So if you have a new left bundle branch block, we should probably look for a corresponding circulatory blockage. A chronic left bundle branch block, not so much. On the right, we see a typical configuration for a right bundled branch block. Now, I think these slides, you can go back and look at the picture of the right bundle and the left bundle on one of those first slides that we showed. A right bundle branch block is notable. There's a slight chance that it might progress to the point where someone might need a pacemaker, but in general, not too much to worry about. Okay.
And Dr. K, on this slide, I know someone earlier asked about the leads. These are both not lead 1 or 2 images. Can you
Mhm.
see a bundle branch block on the first lead, or is it just
It
really visible
depends.
in those later leads?
Most of the EKG machines that you see in doctors' offices, as well as the Kardia, only assess the rhythm using using lead with the Roman numeral 1. That's the one that goes between the shoulders, and it depends on what kind of recording. I saw one of the questions was, is a 1 lead better than a 6 lead? The algorithm pretty much uses lead 1 to make all of the assessments, but as a human reviewer, I like to see 6 electrical angles or electrical viewpoints, if you will, on the heart, like we see with a 6L, and then again a 12L, like we see in the doctor's office. It's really able to provide much more information for a human reader. Does it help the algorithm? Yeah, we're working on it. It's a lot of engineering work. And a lot of it depends on how your particular heart kind of sits in your chest, the quality of the reading that we can get in lead 1.
All right. Well, Dr. K, I just want to say thank you. That was a lot of information. So I hope everyone out
Yes,
there
it was.
feel free to take notes, but we will be sharing the recording. And thank you for all the hearts and the applauses. You all coming to this is just amazing. We are 1,000 people in, so thank you. But I do want to introduce Katie to cover, we now know about arrhythmias. We know how they can burden us or not. But we do want to manage them, monitor them. Katie, can you let us in on how people can use the Kardia device, what features are out there and such?
Yeah, and we're not done yet. We still have this section, and we also have Q&A at the end. So please hang on, and we'll address even more questions
Yeah,
to
we can
come.
go over a little bit too.
Yeah.
Let's keep moving if we can.
All right, next slide, please. All right, so one of the things that you can use that we have in Kardia to help you monitor your arrhythmias is the clinician review. So this is the ability to send any of your EKGs to reviews by our Kardia doctor teams, like Dr. Kozlowski. If you submit one in the US, you may get Dr. Kozlowski as your reviewer. There's a lot of things, as we're saying, we can only identify a few things from our algorithms, but our doctors can look at a lot more. So this is just a list of some of the things that our doctors are able to identify. And again, you're able to access this through the EKG itself. In your EKG history, if you click on the EKG you want to send, you can tap to order a clinician review. So this is an a la carte service. If you are a Kardia Care or a Kardia Care Plus member, you may get access to this as a credit. So you have a certain number of credits every year that you can use to
Yeah,
access this feature. Yeah, use them.
And also, Katie, even if I tell people, even if you're having a normal sinus rhythm report, but maybe you're feeling something or you're having a tachycardia or a different reading and you want to see if there's something else there, go ahead and use one of those clinician reviews. The doctor's reports are so valuable. And this is another case for what Dr. K was saying about tracking more data. Even if you're not getting that determination, that SVT or something like that, the doctor will be able to see that. So great value add.
Great. And I did see we have Canadians on this call. So welcome
All
to our
right.
friends from the north.
All right.
Yes, we have this feature available in Canada in select provinces. It's not available in all provinces, but we have a team of Canadian doctors that are providing this service as well. And I will also plug for unclassifieds. We have a further question about unclassifieds, but if you get unclassifieds, this is a great way to get a second look at that.
And this might be a plug for our Kardia 101 viewing as well. We have another webinar that's entirely about getting the most out of your subscription. So we can share that in the post-webinar email as well.
Yeah. Okay, great. Next slide. Then one last thing, just a reminder that if you are a subscriber or a member, you also have access to additional insights. So you can look at information about the frequency, what day or what time of day you're getting these arrhythmias. These are all meant to be tools that can help you better understand what is going on with your heart and empower you to have a better conversation with your doctor. We did also just recently launch a new feature called Median Beats. a median beat is not an average beat, but it is the most representative beat of the EKG itself. And so now if you are a Kardia Care or a Kardia Care Plus member, you can view this median beat display within your Insights tab. So that's just another piece of data that you can use to look at your EKGs over time and use that to see how your rhythm is evolving.
And Katie, that seeing that beat is just so helpful, that median beat. So anyone with that subscription, check that out because it is really interesting to see how that changes over time and what that indicates.
Great. I think we have one last slide and then questions.
Yeah, all right. And stay tuned for questions at the end, folks. I feel like that's where the meat is. So
That's fun.
we always want to share this slide just because, you know, we have 1,000 people on this call. If we can look out for ourselves and maybe help someone else along the way, we can save a life. So read over these symptoms of heart attack and stroke, and then also look over to the side for that AED emblem. I challenge you wherever you are at a restaurant, at the airport, look for that symbol. Knowing where that AED is at during an emergency can save a life. And to shout out Daniel's team with customer care, they are here to support you. So here is the phone number, the email. But I want to thank everyone from our whole AliveCore team, 1,000+ people on this call, and we do all this just for you. So thank you so much for supporting these webinars, and we look forward to seeing you at our future webinars as well.